Well, for the next 45 minutes, we're going to be talking about ultrasound of the endometrium. It's a nice topic because it can be covered pretty much completely in one session right here. And we'll talk about why we worry, a little bit on terminology and technique. We'll discuss what's abnormal in a variety of clinical scenarios. We'll talk about abnormalities seen on transvaginal ultrasound, other competing diagnostic modalities like endometrial biopsy or DNC, and then we'll finish up with a lecture within a lecture of saline infusion sonohysterography. So why do we worry? About 10% of postmenopausal women will have bleeding, and of that 10% of those will have endometrial cancer. And even though endometrial cancer is predominantly a disease of postmenopausal women, 5 to 10% of cases will occur in premenopausal women. It's the most common GYN malignancy, about 40,000 cases per year in the United States, and it's the fourth most common cancer in women, following breast, lung, and colon. But fortunately, because it's detected early due to the abnormal bleeding, and because we have reasonable treatments for it, it accounts for only 1.5% of cancer deaths. So which of the following statements describes endometrial cancer? All of these are true except it's the fourth most common cause of cancer in women. 5 to 10% of cancer occurs in women under the age of 40 or 50. It's the #1 cause of bleeding. There are 40,000 new cases per year in the US, and there are a variety of risk factors. So all of these are true except it is not the #1 cause of postmenopausal bleeding. It's the cause we worry about, but atrophy is actually the #1 cause. So there's a variety of specific terms with unique meanings regarding abnormal bleeding, but if you're a lumper like I am, you can skip to the bottom and call all of the above abnormal uterine bleeding. How do we measure the endometrium? It's very important that we spend time on technique and try to do things right. Here's a quote from John Wooden, the most famous basketball coach of all times, talking about the importance of attention to the little details. So we want to measure the endometrium transvaginally with an empty bladder. We want to measure it in the sagittal plane. We want to measure the thickest portion. We exclude any fluid in the endometrial cavity from our measurement. We visualize the entire endometrium. And remember that 5 to 10% of the time, you're not going to be able to see the endometrium. You're going to have fibroids or positioning or something that gets in your way, and that's okay. So we measure it transvaginally, and this is just an example from a beautiful paper by Ruth showing how you can see the polyp transabdominally, but as we all know, it's much better seen transvaginally. We exclude the hypoechoic intermyometrium. So as you see on this slide, we measure between the arrows and we don't include the hypoechoic halo. That's just convention. If you have fluid, you measure each wall and add them together, and you don't include the central thickness of the fluid, which makes intuitive sense. So in this case, the reported thickness would be 4.3 millimeters, 0.2 and 0.23. It's really important that we sweep the entire endometrium. You don't want to just take pictures like in the top left and say, oh, everything's normal, because then when you move your probe off to the side there, all of a sudden we have a stage 1 adenocarcinoma that's not seen on the initial image. And again, just to make this point, 5, 10% of the time, whatever, you're not going to be able to see the entire endometrium. That's okay, because the message we want to give our patients is that if we call the ultrasound normal, you do not have endometrial cancer. If we can't see everything, that's okay, but we just need to go to another case, another assessment modality. So in this case, we have a large fibroid up there, and it turned out that there was a stage 2B endometrial cancer here. Don't accept indistinct endometrial margins. Endometrial cancer can be infiltrative. So you can see on our right towards the cervix, we have a sharp line, but towards the left, it's just kind of gray and blending in, and this was a grade 2 adenocarcinoma. So regarding proper measurement of endometrial thickness, all of the following are true except you need to do it transvaginally. You need to do it in the sagittal plane. It should be made at the thickest portion of the stripe. Fluid within the cavity should be included in the thickness, and indistinct margins should make you worry about cancer. And all of these are true, except as we talked about, we do not include fluid within the cavity. So what's abnormal? And that depends on the clinical scenario. So we'll go through a couple different clinical scenarios here. Number one is premenopausal, and obviously endometrial thickness changes depending where you are in your cycle, but a rough rule of thumb is 15 millimeters. So here are just a series of different patients illustrating the endometrial cavity at different portions of the cycle. Here we have a 20-year-old on oral contraceptives on day 4. It's just thin and atrophic. Here on day 7, you see the periovulatory or beginning periovulatory appearance. It's kind of trilaminar or 3 layers. On day 14, you get the classic periovulatory trilaminar appearance. On day 17, it starts to thicken up and you get this echogenic material. And then as we get into the late luteal phase, the entire endometrium, these are 2 different patients, is just very thickened right there. So that's the normal spectrum from menses to right before the next menses. And remember that this 15 millimeters is not a perfect threshold there. This is a 2.5 centimeter endometrium in a 29-year-old asymptomatic patient one day before she's supposed to get her period. And she's asymptomatic, she's young, this is going to be normal here. So what you want to do to try to obviate these problems is schedule people for their ultrasounds on the early part of their cycle, and then you won't run into the conundrum posed by the secretory phase. Scenario number 2 is postmenopausal bleeding, and basically under 5 millimeters is normal. Some people used 4, but the majority of everybody uses 5 millimeters there. Remember that there are some nuances to this 5 millimeters. If you have a focal endometrial abnormality, that's abnormal even if it's under 5. So if it goes 1, 1, 1, 4.9, 1, 1, 1, that's abnormal there. We talked about an indistinct appearance. Most of the time it's normal, but it could be cancer. And 5 to 10% of the time it's going to be non-diagnostic because you can't see, generally due to fibroids. Remember not to scare your patient. Just because the ultrasound isn't under 5 millimeters doesn't mean she has cancer. It just means that we need to go to a more definitive test. The whole goal of ultrasound is to have something that, when it's normal, there is not any cancer. Third scenario is the postmenopausal patient on hormone replacement therapy. And there have been a lot of oscillations in whether women are being offered peri or postmenopausal hormone replacement therapy over time. But bottom line, we keep the 5 millimeter threshold. We're not using the 8 millimeter threshold that a lot of people talk about, but that's not evidence-based medicine right there. We keep 5 millimeters because if it's under 5, it's not cancer. We know we're going to have more false positives because the hormone replacement is going to increase the stripe thickness, but there are enough cancers between 5 and 8 that we keep the 5 millimeter threshold and accept more false positives. And here's a 55-year-old on unopposed estrogen for 5 years after menopause, and you can see the thickened stripe with blood flow.